pituitary. So again, it's usually prolactinomas and then growth hormone secreting tumors and then the other stuff. But you're right, parathyroid is the most common. 90% of MEN1s will have hypercalcemia and parathyroid problems. A lesser degree will have pituitary, and what's the last piece? Papillary, good guess. Not papillary. Think further down. The pancreas. So pancreatic tumors, so not pancreatic cancer, that you're like adeno-CA, but insulin secreting tumors, insulinoma, and gastrinomas. So the third piece is a little misleading because most gastrinomas are actually in the duodenum. It's like your classic Bollinger-Ellison syndrome. They just have horrible hypersecretion. Insulinomas obviously are going to present with weight gain, passing out spells, and low sugars. Okay, so most of the time the calcium's the easiest thing to pick up on. The other stuff you kind of screen for based on their symptoms. Malaise, 45-year-old woman with malaise, fatigue, and weight loss this time. She has autoimmune thyroiditis, so she basically has hypothyroidism. She's on appropriate medication with normal labs. Her blood pressure may be a little bit low or normal, but she's orthostatic. She has a firm thyroid gland that's normal size, which is pretty much what you see with hypothyroidism. But she has increased pigmentation, and then these lab findings, which I think are kind of the key. And here's another question, which just basically is what's the diagnosis? Okay, so one autoimmune disease already. She's hypotensive, pigmented, hyperkalemic, hypercalcemic, and looks like she's under-replaced as far as her thyroid goes. So what's causing her symptoms? D, yeah, you guys know this, so that's D, okay? So yeah, she's insufficient on her thyroid hormone, but TSH of 8 will not make you feel this way and certainly won't give you a potassium of 5.9. One thing that's not widely known is Addison's very often presents with mild hypercalcemia and sometimes even mild TSH elevation. So these are folks who don't have hypothyroidism yet. It's very common to see calciums of 10.5 to 11 and TSH is of 4 to 8. It's not super well known why that is, but they do fine once you start them on hydrocortisone and fludrocortisone. So these are patients who do need hydrocortisone and often fludrocortisone as well, which is different from your pituitary adrenal insufficiency where they just need hydrocortisone, remember, because they still have their melanocorticoid intact. So this is a 48-year-old gentleman now with possible primary aldosteronism. So his ratio is very high. So what's considered a high ratio for aldo to renin? Any guesses? Yeah, 20, 15, 20. It depends on what you read or what studies you go by. But 48 is clearly abnormal. I don't think they'll give you a borderline level. Aldo is, again, very high. Anything over 15 to 20 is considered pretty high in this setting. And they didn't give you any medications, which is good. So primary hyperaldo evaluation is kind of difficult, again, in real life, because these are hypertensive patients who have been on lots of drugs, and lots of drugs can interfere with the evaluation. The most annoying one being spironolactone, because it takes about 6 weeks to wash out. You have to get that off. But you can just look at a list of drugs that typically have to be discontinued. The ACE inhibitors can cause a false negative in the other direction, beta blockers. So basically, you wind up on calcium channel blockers and hydralazine to evaluate them. That's typically how I do it. But they thankfully don't give you any of that. She also has a high 24-hour urine aldo collection. Her adrenal glands or his adrenal glands are normal. So it's not a big Conn syndrome tumor. What do we do next? So we can just do another picture, because why not just do an MR? This is way out of left field, but this is because of the people who don't study endocrinology at all and go take the boards, because it sounds like something in endocrinology order, but you all know inferior petrosal sinus sampling is up here and it has nothing to do with aldosterone. So if you just look at one algorithm, you can cross that out. You can sample the adrenal veins, which makes a little more sense, some fancy adrenal imaging, or an ultrasound. Thoughts? So for CT is negative, do you think the MRI is going to show a large aldosterone? Likely not, okay? So forget that one. You know, you go back and forth between CT and MR of the adrenals if you're trying to look for characteristics of a lesion. You know, sometimes PHO is one of those lesions. Cancer is one of those things where MR has certain features, CT has certain features, and they're complementary. But if you're just trying to find out is it there or not, it's unlikely that one versus the other is that much better. Okay. Thoughts between CD and E? What sounds kind of reasonable? C. I think C sounds reasonable. That's right. Okay, so this has nothing to do with aldosterone evaluation. It's a whole different test. But adrenal venous sampling is exactly the same principle as betrothal sinus sampling. Which adrenal is it coming out of, or is it lateralizing to one adrenal or not? Because you could have a small tumor that didn't show up, and if it's clearly lateralizing to one, it might be a surgical candidate. Most of them are not going to lateralize, and they just need medical management of their hyperaldo. Okay.
You had a question, Elaine?
Yeah.
Elaine? That was about Theo. Okay, never mind.
Never mind. Okay. Don't do adrenal venous sampling for Theos. Don't do anything to Theos until you get them adequately controlled blood pressure-wise. Okay. So if you want an algorithm, this is one potential algorithm for evaluation of primary hyperaldo. So these are the people who you suspect might have it. Refractory unusual hypertension, which could be a lot of people. Hypokalemia, a lot of these people don't have hypokalemia. That's a little bit of a myth, but that's kind of a red flag that you should evaluate for this. And obviously, if you're evaluating incidental adrenal mass and they're hypertensive or hypokalemic, you need to evaluate aldo. So you just do the ratio. These are 15 to 20, if you can remember for both of them, I think is enough. If you confirm biochemically, then you get to go looking anatomically. That's another kind of important thing in endocrinology, always confirm biochemically first. So this is a little bit of a moving target. A lot of people won't even do this anymore, but in general, if it's a really big mass in a really young patient, you can just take it out because you can assume that's where it's coming from. But from all the scans you guys have done, you know lots of people have adrenal masses. So it would be a tragedy to take out an incidentaloma when it was the other adrenal that was making. So a lot of times people will do, some people do, at NIH and the big centers, they do AVS in everybody. At smaller centers, you know, if you're not that great at doing AVS, you don't want to subject everyone to it. But older patients, smaller mass, bilateral masses, nodular adrenals, basically most people go to sampling first. Okay? And you either take it out or manage it medically. Okay, so the testicles and male hypogonadism. This is just a reminder of the axis, the hypothalamus, pituitary, and the testes. So primary is unusual. I don't think many of you see much primary in the general medicine clinics. There's almost always Klinefelters if we see it and it's unknown. If it's chemotherapy or something like that, you know why it's occurred. But the idiopathic cases often ends up being Klinefelters or we just don't know. If it's secondary hypogonadism, it's these things we talked about, things that affect your pituitary. This idiopathic aging category is probably the most common thing out there, and you guys see a lot of that in obese, older, diabetic men who you're testing. They'll have testosterone from 180 to 250, and you're not sure quite what to do with that, and neither are we, but you often treat it. Okay. So this is a 24-year-old man, a young guy evaluated for infertility. So he had normal puberty, but then around age, and stopped growing at age 20. Still shaves, but now once a week. That's never increased. He smells normally, which is important because there's a disease called Kallman's syndrome, where you have midline defects and they never develop, and they don't smell and they don't have pituitary insufficiency. Whoops. So he has normal blood pressure, normal fields. He has 3 centimeters gynecomastia and firm, very small testes. Remember, 4 millimeters is really small. Very low testosterone, very high LH and FSH. Okay, so what does this guy have? He has Klinefelters. This is classic Klinefelters. So what do we do next? I think I heard it. Yeah, karyotype. Okay, so that's a very satisfying diagnosis to make. It's easy, karyotype. So all these things don't really have much of a role. If the karyotype is negative in this patient, we often just treat him with testosterone, and if he and his partner want to achieve pregnancy, you can do things like do intracytoplasmic sperm injection if there's any sperm left. Because some of them potentially can get pregnant, but get their partners pregnant. But mostly it's Klinefelters. So he's an older gentleman, 42, again with decreased libido, erectile dysfunction that's gradual. He's shaving every other day. His exam is fine. His testes are slightly soft. His skin is a little tan, so that's a little red flag, but he's been on vacation. He has diabetes in his family, and there's his lab studies. So he's diabetic based on his fasting plasma glucose. His LFTs or his AST, ALT are a little high. And you repeat it, and it's not as high, but it's still technically diabetes. So which of the following will most likely confirm the diagnosis in this patient? When you kind of first start reading it, it seems like maybe he's going to have this idiopathic male aging syndrome, except he's not really aged. 42 is not old. And then he has some other red flags, tan skin, diabetes, in himself and his family. So what is this? Yeah, this is hemochromatosis. So what test are we doing? A, okay? A. So it's to confirm the diagnosis, and so iron studies is kind of generic. And you're going to expect his FSH and his LH to be low because this is pituitary infiltration. This is secondary hypogonadism, okay? And he's younger. So I just diagnosed a woman today with hemochromatosis in the clinic. But she was 59. She had a late menopause at 56. She got diabetes at 57, and she started being able to tan really easily. She's had AST, ALT that's chronically high for the last 3 years only, and was told that she had fatty liver and diabetes and lose weight. She's trying to do everything she can, and her ferritin and trans fat are super high. She's from South America, and so when I made the diagnosis, I thought I was so cool. I said, oh yeah, my son who's 32 has that, and he has a liver biopsy done, and he's being followed with phlebotomy. So she never told her primary this, and he's just been treating her with metformin all these years. Yeah. So I was very proud initially. But anyway, so women get it later in life, obviously, because they're bleeding up until the 50s. So this is a 69-year-old man who has gradual symptoms, weakness, libido, loss in sexual function. He has mood swings and hot flashes, because remember, men need estrogen too. They just get it from their testosterone. Testosterone gets converted peripherally to estrogen in men, and that's how testosterone maintains bone strength. It's not necessarily directly. Okay, so men with aromatase deficiency can have tons of testosterone and still have weak bones and fractures. He has a little gynecomastia, small prostate, borderline sized testes, and then here are his labs. 174 is his testosterone, so again low, but not rock bottom. They repeated it at 186. His gonadotropins are inappropriately low normal, so this is a secondary hypogonadism. PSA is fine. What do we do next? So they gave you something fancy. They threw in an FHBG. So then you get scared and you think, maybe I should just order another fancy test. But don't let them confuse you. You know what this guy has. He's just older, and he has the same old hypogonadism that you see all the time. Okay? So what should we do? There are a couple of right answers, and I think people would do something different. Some people might get an MRI just to say, you know what, I don't want to miss a big tumor, and maybe this is how it's going to present in this guy. The answer is actually B, is just to go ahead and replace his testosterone. This is the one scenario where you don't have to get too caught up in worrying about if there's a tumor there or not. This is the other thing. They checked his prolactin, it was normal. I might have left off TSH and free T4. So basically, if all the kind of pituitary-looking stuff is normal, and they're old, and it's gradual onset, and it's not FSH and LH of 0, the answer is just to give testosterone back. Okay. So again, another older man who was diagnosed with hypogonadism. He was placed on treatment. This is standard injection doses. So you guys are probably used to giving androgel or Testosterone daily, but if you do injections, it's 200 every 2 weeks to start with. And so he feels good. You check his levels a day before his injection. So that means it's been about 2 weeks since he got an injection, and his level is now 164. So it's kind of low still. His hematocrit has gone up. His PSA has gone up. And there's his PSA today. It's up to 5.2. So what should we do next? Should we go down on his dose because we're worried about all this? Should we change him to gel, keep on treating him, hold it and resume it, or just stop it and send him to urology? Yeah, absolutely. So we stop it and send it to urology. So testosterone doesn't cause prostate cancer, but it will cause growth of any occult small tumors that are testosterone sensitive. So that's clearly abnormal. That you can use whatever yearly rate you want. I don't think they'll get so nitpicky as to ask you if it's 1 milligram per deciliter over 1 year, but it's over 4. It's high. Hematocrit should go up when you start testosterone therapy. PSA often goes up. These people have PSAs that like nothing because they've had such low testosterone, but it should go up to 1 or 2 at most. Okay. So calcium and bone is actually fairly quick. So the only thing you really should remember about calcium algorithms is it PTH dependent or not? If you can just remember that, I think that will get you through a lot of boards questions, because PTH causes calcium resorption from the bone, calcium reabsorption from the kidney, and then your vitamin D stimulates absorption of calcium from the gut as well. So for calcium, you need to know how to recognize and treat hypercalcemia and work it up. Most of these questions are going to deal with PTH-dependent syndromes. So parathyroid adenoma,